Good morning. I'm John Huxter and I'm the Cognition Lead at Transformation Limited in the UK. This poster describes our efforts to validate the use of 40 Hz ASSR for pharmacology using rats treated with ketamine to impair their NMDA receptor function. ASSR stands for Auditory Steady-State Response. It's a rhythmic brain response evoked by repetitive click sounds as picked up by scalp EEG electrodes. The clicks entrain interneuron networks which naturally resonate at gamma frequencies. Abnormal ASSR is well characterized in people with schizophrenia, and it's currently used in clinical trials for schizophrenia, autism, Down syndrome, and of course hearing loss. ASSR is driven by the auditory cortex, but in rats, the coordinates, shown here in blue, are surgically challenging. So we wanted to develop an ASSR protocol using our standard electrode placements for sleep-EEG, which are shown here in pink. 9 animals were implanted for EEG, and after 2 weeks recovery, we tested 6 different click stimulus protocols. At right, as an example, is the final protocol we used for the pharmacology studies. Each click is a 1 millisecond square wave followed by 24 milliseconds silence, with a train of up to 200 clicks constituting a trial. Here the trial is 1 second long. Trials needed to be long enough to allow an FFT analysis. The interval between trials was from 1 to 2 seconds, and we aimed to keep the blocks of trials short for tracking pharmacodynamics. The power spectrum was first derived for each trial and then divided by the spectrum for the baseline period before each trial. The ASSR was calculated as this power ratio at 40 Hz. ASSR was then averaged across trials in each block. At the top right are unnormalized spectra from individual animals for 3 of the 6 protocols we tested. 1 second trials were found to allow more precise measurement of the 40 Hz response than half-second trials. We were also able to reduce the intertrial interval without adversely impacting signal strength. The bottom left panel shows the stability of the evoked response across trials, and on the right are the average normalized spectra for each protocol. Only the evoked 40 Hz response and its harmonic survive this baseline normalization. There is no evoked response from the neck extensor muscle, demonstrating that this is not merely an artifact. For the first pharmacology study, animals were dosed once per week for 5 weeks with either vehicle or ketamine at 4 different dose levels. All animals received all treatments. The raw spectra down below shows a dose-dependent increase in spontaneous gamma power, which is typical of ketamine. Riding on top of this is the evoked 40 Hz response, but this is clearly lower for the higher doses of ketamine. The effects are even more obvious when we correct the spectra for each animal's vehicle treatment results, as shown on the right. A repeated measures ANOVA revealed a significant reduction in ASSR for the 10 mg/kg dose of ketamine. The reduction was almost total initially and remained significant for about 30 minutes before gradually returning to normal. Next, the same animals were treated with either vehicle or the higher 10 mg/kg dose of ketamine, but were also pre-treated with either aripiprazole or clozapine. Dose times were selected according to the pharmacodynamics of each drug for maximal efficacy at the time ketamine was given. Here again, ketamine dramatically reduced the ASSR. However, neither antipsychotic prevented this reduction, nor did they significantly alter the time course of the effects. Our main conclusions are as follows. Number 1, midline EEG recordings can detect a robust, reliable ASSR provided the stimulus and normalizing parameters are optimized. Second, subanesthetic doses of ketamine at 10 mg/kg can impair this ASSR, pointing to a relevance for models of schizophrenia. And finally, Atypical antipsychotics do not appear to reverse this ketamine deficit, suggesting that the ASSR may not be mediated by serotonergic receptors. Our future efforts will explore other pharmacological routes of reversing deficits due to NMDA receptor antagonism, as well as other disease models. In addition, we will be testing ASSR evoked by quieter clicks, which may be more easily impaired and also more easily recovered. And with that, I'd like to thank my co-authors, Sandor Cantor, Lauren Giggins, and Mark Doxson, and also our operations lead, Cole Taylor, who made organizing all of these experiments possible. Thank you again for your time, and I look forward to your questions.